or so. Welcome. The space that you're in is Social Medicine Rounds. We are very excited. We're always excited, but we're especially excited today because we have a Monty alum joining us as one of our speakers, Dr. Catherine Trimbur. And I believe Catherine's parents are also on. They joined a little earlier and I got to say hi. And so it's just, it's family together, and also a good friend and new sister friend of mine, Dr. Topeka Sam, is joining us today. So we'll do our usual. I'll acclimate you. I'm Stella Sappho, for those who I haven't gotten to be on this in this space with yet. I'll acclimate you to what our rounds are, and then we'll go ahead and get started. Okay, so we are meeting today at a time in the world where I think there is so much going on that we can't not, acknowledge kind of the heaviness that we are all feeling and a part of. And so I just want to, I'm sorry, my slides are going a little crazy. Can folks see my screen? Yes, okay. I just want to take a moment and acknowledge this time that we're in, the difficulty of this time, the feeling of wanting to support, of wanting to speak out, of wanting to be in solidarity with those that we love and with humanity. And so for those that I think are on here with a heavy heart, I certainly feel that way, and I certainly hold that. And I'm glad that we're having a conversation about a topic that I think brings similar principles of how to address systems that are unjust. And so my hope is that we can have a generative, respectful, and good conversation today with our speakers. And so what are social medicine rounds? For those who are new to this space, social medicine rounds are an opportunity for different groups from different walks of life. So those of us that are in academia, as trainees, as faculty, as staff, and those who are in our Bronx community and nationally, to come together to talk about different issues that impact health, certainly in the Bronx and also nationally. And so some of the issues we've talked about are the impact of social movements like the Young Lords movement, how to address the opioid crisis, what we have thought and thought through with COVID-19 and sharing information around that. And this topic that we're kind of entering again around criminal justice reform and the need to be really mindful of how we do that work. I am really, really excited to have two speakers joining us today, and I'm going to go ahead and turn it over to Dr. Iyer to introduce them.
Hi, everyone. It's so nice to be here today with our speakers, our wonderful speakers. I'll introduce them in just a moment. I also just wanted to welcome all of the applicants that we've invited today. Welcome, welcome. This is something we do every month, and we have a really incredible lineup of speakers and topics. And so thank you to Dr. Sappho for arranging for these rounds for us. So I'm going to go ahead and introduce our speakers. Our first speaker is Dr. Topeka K. Sam, who's the founder and executive director of the Ladies of Hope Ministries, co-founder of Hope House NYC, president of TKS Ventures LLC and Faces and Voices Incorporated. She serves on the board of directors for Grassroots Leadership, Coalition for Public Safety, and the Marshall Project. Since her release from federal prison in 2015, Dr. Topeka has been awarded many fellowships and scholarships, such as the 2015 Beyond the Bars Fellow and a 2016 Justice and Education Scholar, both from Columbia University. A guest on a variety of national TV and radio shows, she's also an executive producer of 44 Blue Productions, where she's developing a scripted and unscripted series inspired by her experiences with female incarceration. She continues to work selflessly and relentlessly in her fight for the dignity, decriminalization, and decarceration of women and girls. Welcome, Dr. Topeka Sam. And our other speaker today is Dr. Catherine Trimbur, who is a primary care physician who's triple board certified in internal medicine, addiction medicine, and palliative care. She works at Lifespan Transitions Clinic, where she collaborates with peer recovery specialists and community health workers to provide comprehensive care for people with histories of carceral exposure, with a focus on those with serious illnesses and substance use disorders. Dr. Trimbur also provides pain management and palliative care consults at the Rhode Island Adult Correctional Institute, the state's unified prison jail system, in addition to her clinical work, she's dedicated to medical education and has developed a psychosocial curriculum with an interdisciplinary team to help medical residents maintain empathy and reduce stigma when caring for marginalized patients. Dr. Trimbur, welcome. So nice to have you back. I can't remember when you graduated, but maybe that's not important. So
wonderful. So we're going to go ahead and get started, and I'm going to turn it over to Dr. Sam to kick us off.
Hello, everyone. Everyone hear me okay? Because I hear a lot of breaking up. I don't know if it is me
It might
and
be
where I
you,
am, but
Topeka.
it might be me. I'm in a hotel in Oklahoma. So let me see if I can do something about this Wi-Fi, which I doubt, but
Topeka
I'm
is
going to
always
try.
on the go, so
Can't have two people.
Yes, speaking about all the issues. So let me see what I can do.
and if you need to, if you want to go off
1 second. I don't
camera
know if
for a
Dr.
moment, and figure that out, I'm happy to switch us over and we can start with Dr. Trimbur. Let's do that. I'm going to let Topeka figure out what's happening on her end. Catherine, do you mind getting us started?
Sure. Yeah. And Topeka, if you get ready, I can we can switch back over too. All right. So I'm gonna try and share my screen. All right. Are you guys able to see?
Yes.
You're able to see my screen? Okay. I can't figure out how to get it to All right. Everybody can hear me and see the screen?
Yes. Do you want to do slideshow just on the bottom?
Yes.
Just go down to the right.
This one.
2 more over.
2 more. There we go. Thank you.
You're welcome.
All right. So you can see everything?
Yes.
Okay. Well, thank you all. Thank you for having me today. Dr. Sappho, thank you for having me back. It's really, really nice to be back with an old crew. So I'm really excited to be talking about how to support people who've been exposed to the criminal legal system in community entry, re-entry. So as Dr. Iyer said, I'm a primary care doc, a palliative care doc, and addiction doctor here in Providence. And I care for people in our transitions clinic, along with a crew of amazing peer recovery specialists and community health workers. The only disclosure that I have is that the majority of what I'm going to say, I've learned from my patients and the community health workers with whom I serve. And so a small amount are my own ideas, but hopefully I'll be sort of representing our crew well. In the interest of time, I'm not going to spend a whole lot of time reviewing the history of how the prison industrial complex came to be, other than to say that the direct lineage really can be traced, starting with plantation slavery, moving through the Jim Crow era, and then transforming into the mass incarceration phase, which is what we find ourselves in now. I'm also not going to go into a ton of detail on the negative health impacts of incarceration. There's robust data demonstrating this, and we've included some additional references for both the legacy of the prison industrial complex and the mortality and morbidity associated with incarceration in the resource links. So at the time that we do have, I wanted to start our time together by really setting up a framework for a humanist approach to caring for folks as they return home from confinement, and then go on to discuss some tools to operationalize this in practice. So let's begin with a very brief discussion, I promise, of 2 activists and philosophers who really help us frame a clear understanding of the prison industrial complex. The works of Frantz Fanon and Michel Foucault around conceptualizing power and resisting oppression really help us open up avenues of direct clinical interventions for our patients and who were exposed to the criminal legal system. So Frantz Fanon was a psychiatrist and philosopher who worked in Algeria during their struggle for independence from France. During this time, he took care of a range of patients, but among them were French soldiers.
Sorry, Catherine, if you're forwarding, we can't see you forward.
Oh, thank you. You knew I wanted to go there. Thank you. And is this blocking? Can you all see?
We can see everything. You're good.
Okay, awesome. Thank you. Thank you for the reminder though. So during this time, Frantz Fanon took care of a range of patients, and among them were French soldiers and Algerian civilians, so people sort of on both sides. And it was his clinical work that really led to his writing about the dehumanizing effects of colonialism and the ways in which oppression becomes embodied and causes both physical and mental illness. So while his work primarily focused on the decolonization of oppressed nations, his insights really are important to apply to those affected by incarceration as well, in the same way that the colonizer's existence is really predicated on the colonized being inferior. The prison guard, the warden, the CO are all constructed as superior. And the incarcerated person's existence within the walls of the prison is predicated on an inferiority and thus leads to degradation of their humanity. And living in this structure and under these conditions becomes embodied. It happens in different ways for everybody, and there isn't homogeneity in how people experience oppression or how it impacts people's bodies, minds, souls, and health. But we see this in clinic, and so it presents in the clinic in a variety of forms. And Frantz Fanon really argued for a new radical humanism as a means to truly liberate the oppressed. And as a physician, he believed in the transformative power of healing a patient. So this approach really recognizes that the terms of confinement are designed to dismantle one's sense of self and dignity. Thus, the work of healing for incarcerated and recently decarcerated individuals necessitates a fundamental understanding that they're deserving of care that not only treats physical ailments, but also supports their emotional and psychological well-being and really aims to restore a sense of dignity. However, the hierarchical nature of the prison industrial complex can too easily transition into a parallel hierarchy in the medical industrial complex. So the power dynamics that are structured in prison, I think for a lot of people, are also felt within the clinic. The carceral state follows people and finds its way into the clinic room with you or the patient. So our jobs then as clinicians is to engage with patients to truly tend to their humanity. And this requires a real partnership with the patient using shared decision-making, as the patient really is the expert in themselves and their experiences. And the clinician needs this expertise to appropriately care plan. So Michel Foucault also talks about the parallels between the prison and the clinic. In his book, Discipline and Punish, The Birth of the Prison, he discusses modern forms of control and discipline and the transition of punishment of the body and to include that of the mind. Central to this, both literally and figuratively, is the panopticon, which is this system of surveillance that includes a tower where the prison guard sits in the middle and can see everyone, but not all prisoners can see him. And thus you don't always know if you're being observed. The goal of this is to make people internalize that gaze and exert control over them at all times. And the goal and both the impact of this is a constant state of unease. Again, this unease can present in a myriad of ways when you are seeing people upon release. In The Birth of the Clinic, Foucault also talks about a medical gaze, and this he describes the power of the in the development of teaching hospitals and clinics. So the medical gaze, just like the gaze of the panopticon, is used as a tool of power to control in the clinical setting, and it's really meant to sort of organize both providers and patients. The ways in which doctors observe, the false notion that it's done objectively, and that the documentation of these observations and the conclusions that we draw from these observations, all done without patient partnership, produces a power dynamic and separates the patient, the body, from their humanity. So I think without reflection on the hierarchy that we're really practicing in, we miss an opportunity to understand the residual impacts of incarceration on patients as we care for them upon reentry. So patient after patient tell me about how the doors shutting at clinics sounds the same as the doors shutting in the prison. The lights flickering feel the same. And sometimes being in a hospital feels like they're in prison again. Many have reflected that inpatient units in the hospital with security, with unprovoked checks, can feel like they're being in prison. Part two, that's how they describe it to me. So recognizing that these institutions are structured to disempower certain bodies and communities really allows us to see a path that aims not to reproduce the hierarchy, but to bring the sociopolitical context into the clinic and really see the transformative power of healing that Fanon wrote of. So again, this lens allows us to reflect on why caring for people with exposure to incarceration really requires an awareness and integration of this sociopolitical legacy. Then we can begin to see that the most subversive tool that we have is recognizing the humanity and the dignity of the patient in front of us. Engaging in healthcare can either be a re-traumatizing experience or a transformative healing process if we seek to dismantle the systems of oppression by prioritizing the genuine well-being of people affected by the criminal legal system. So I'm going to spend the rest of the time that I have, and Stella, you'll cut me off because I'll talk about this for days, but I did time myself. So I do want to spend the rest of the time that we have to talk about the ways in which this humanist perspective can really open up avenues for clinical interventions in ways that a traditional biomedical framework doesn't always illuminate. So as we briefly discussed earlier, incarceration is bad for most people's health. Therefore,
Sorry, Catherine, I apologize. Are you forwarding?
Oh, nope. Oh, no, now I am. Yeah, I'm going to forward it in a second. Thank you.
Cool.
So as we briefly talked about, incarceration is bad for most people's health. Therefore, in my job as a doctor, I must see reincarceration as a profound risk factor to be reduced in my patients. This means providing support as they navigate the parole and probation system, advocating around safe and permanent housing, and leveraging all of my tools and privilege as a provider to reduce the risk of incarceration and improve their well-being. These are really the principles upon which we grew our transitions clinic here in Providence. And early on, we had a patient who was at risk for reincarceration, and we all sort of had this feeling of defeat because we know about what those implications are. And so our team sat down to discuss it, and one of the community health workers, with all of his wisdom and his own experiences, said this patient's been working so hard on all of these things. He's about to get housing, and he's going to lose all of this if he gets reincarcerated. The judge doesn't know any of that. What if the doctor wrote a strengths-based letter sharing all of this info that the PD and the judge otherwise wouldn't know about? They would just see their rap sheet. And this was really the start of us developing letter templates to advocate around the specific needs for patients. And I want to highlight this like at every level, but at this level, the physician was not the one who thought about this intervention, right? It was the community health worker with his expertise who brought this tool to the table. So I'm going to talk about just a couple of examples, very concrete examples of how we actually do this in the transitions clinic. And now I will finally move on. Thank you. So the first example is really just helping patients navigate community surveillance and the financial cost of being in the system. So we know that bond is expensive, but I think we talk a little bit less in our world about how expensive it can be to be on probation or parole. If you have regular urine drug screening, if you have an ankle monitor, if you have court dates, all of these carry fees in many states. And this is an important way in which poverty continues to be criminalized. If you can't pay these fees, it's a violation, and the person is then at risk for reincarceration. However, many states do have some degree of discretion at how to assess and collect these fees. So in Rhode Island, we've worked with the public defender's office and judges, as well as a law clinic at Roger Williams, to develop these letter templates that share the specific negative health impacts of these costs on the patient that we're caring for, and to advocate for the fees to be waived. So in these letters, importantly, we don't make a legal recommendation. Instead, we share the context that the PD or the judge otherwise wouldn't have in the case. So the Fines and Fees Justice Center put out a report in 2022, 46 states are using ankle monitoring programs. If you can't pay, it's a violation and you could be reincarcerated for this. As such, patients will often have to make decisions between paying for meds or paying for their bracelet, paying for healthy food, which is more expensive, or paying for the bracelet, paying for co-pays to go to the doctor versus the bracelet. So this is really a site of advocacy for providers to share the unintended health consequences of the cost and this impact of surveillance. So consider, for example, a patient with diabetes, hypothyroidism, heart failure, PTSD, and steroid-dependent Crohn's disease. She's on SSI, and she returns to clinic after 3 months of incarceration and has an ankle monitor. You're super excited to see her get back on top of all of her care, do some blood work, do her DEXA scan that's overdue, and some other healthcare maintenance. You find that her TSH is really high despite being on her levothyroxine while incarcerated, and she's got this new swelling in her legs that the ankle bracelet is really irritating. She shares that her Medicaid wasn't turned back on yet when she was released from prison. She's been out for a little more than a month. And so she's not been able to take her levothyroxine since then. She can't afford it because of the fees that she's trying to keep up with for the ankle bracelet. Thus, as a physician, you can provide documentation of her not being able to provide to afford these medications, as well as the risk of intermittent swelling in her lower extremity that is negatively impacted by the bracelet. Sharing the negative health effects of the cost of the bracelet and the potential improvement of health without the fees or without the bracelet allows the parole officer to consider waiving the fees or even waiving the bracelet. In this particular case, who's a patient of ours, the PO waived both the back fees for the bracelet and terminated the use of the electronic monitoring for this patient. We've used similar approaches to addressing the impacts of court fines and fees. So in New York City, like in Rhode Island, there are fines and automatic charges that are assessed as part of being arrested, getting booked, going to court, and being involved in community surveillance. Judges in New York, like in Rhode Island, actually have the discretion to waive or reduce fees if a fee waiver request is filled out with the court. There's no formal form. So again, this is an example where we would use a letter template to describe the negative health impacts of the cost, and importantly, highlighting the strengths of the patient to give to the judge that additional context. Again, we're not offering legal advice or judgment, simply requesting that the health impacts be taken into account when reviewing the fees in a court fine appointment. So this is an example, and I'll make sure that these are all in the resources, and I'm happy to share any of our letter templates with anybody as well. But this is an example of the letter template that we would use. And so we just say that we've noticed some negative health impacts despite social and other challenges. We highlight the strengths and the resilience of the patient. Folks who are coming out of prison have an incredible amount of strength that usually the judge or the PD sometimes doesn't even see. And so including that in the letter is an important piece as well. All right, so finally, partnering with local public defenders, whether in a formal medical legal partnership or in an informal way, can be really powerful for patients as well. So at Monte, you have an active and important PD's office with the Bronx public defenders. And just very quickly consider another patient, mid-40s, with head and neck cancer, cocaine use, which is primarily used to stay vigilant at night in his tent because he's currently homeless. He's undergoing chemo and about to get housed in an assisted living facility. And he has a warrant for his arrest. You know that he will lose his housing as well as have interruptions to his chemo schedule if he's reincarcerated. In this case, you would share a letter describing the treatment that he's been able to engage in, discuss plans for alternatives, so possible residential treatment or a partial hospitalization program if that's appropriate, versus just intensified treatment. So a lot of times my letters say, I'm going to engage with the patient more. The CHW, the peer recovery specialists, we're going to support them a little bit more. We're working on housing and sort of outline again the strengths. And we also would highlight for this patient the potential negative impacts on interruptions in care and the loss of this housing opportunity. Going to prison doesn't ever help anybody get better housing. And so you share the letter with the PD who's on the case, who uses it to advocate for the warrant to be terminated. Again, in this particular case, the warrant was taken away, and this patient has outlived his prognosis by 2 years and is safely living without any reincarceration in assisted living for the past 3 years. So there are a number of other practical tools that we use in transitions clinic, really with this humanist framework, from documentation that supports SSI applications, making sure that the medical record supports that, to documentation to support disability bus passes, or in your case, the MTAs, the subway passes, to disability verification, which can open up housing opportunities, and character letters to support applications to subsidize housing for people who have criminal records and therefore on first glance would be refused from housing. So we can talk about, if there's time in the question and answer period, but as I said, I'm also happy to share any of these templates, which again, really have grown out of the wonderful work of my team here in the Transitions Clinic. So thank you for letting me have this time.
Trimbur, thank you so much. And, we went out of order because we wanted to start with kind of high level with Dr. Sam and then come to you for the practical, but your kind of recapitulation of the humanist approach to this was really, really excellent, and is a great way for us to think about the sociopolitical leanings that really inform this work. I want to turn it over to Dr. Sam, and we may have to listen to her through a dial-in because of her the internet, but I'm hopeful that she will be able to chime in and offer us her firsthand experience, because, and I didn't mention this earlier, my apologies, one of the things that we really value with Rounds is thinking about how we learn from those with lived experience, as well as those who are clinicians or in the medical system, and that balance is often missing for many of us who are doing this work. And so it felt really important to offer the space to someone who has literally lived this and does incredible work advocating around it. So Dr. Sam, please take it away.
Okay, can everyone hear me now?
Yes.
Fantastic. Okay. Thank you so much. Okay. Thank you so much, Stella, Dr. Sappho, sorry, and Dr. Trimbur. I was able to hear your presentation, which was incredible. And it made me feel really, really hopeful about medical professionals and seeing change that can potentially happen inside and outside of the system. And all of you here who care about, people like me. And so just to give you a little context, and I'm going to kind of weave my own personal experience with the system, some of the legislation and the advocacy that we have passed nationally, specifically around, conditions of confinement and things with women and children specifically. And then we can talk about additional work that we do around housing and just making sure that the basic human rights of women and girls are met, which is important for the mental health, wellness, and well-being of people who are incarcerated and coming back into community. And so just for me, prior to my incarceration, and I was incarcerated in federal prison for 3.5 years for a nonviolent drug conspiracy charge. So I was charged with selling 80 kilos of cocaine with no drugs. So, there's oftentimes where people are actually sent to prison for either what they call ghost dope or even ghost money, where they'll get these sentences based on obviously sentencing guidelines, cooperation, and what other people say could have potentially happened. And it can send you into prison. And many people who are aging in prison right now are there decades in life for nonviolent offenses. Now, as an advocate, I don't differentiate between the two of violence and nonviolence, especially for those with women specifically, because what we see are the drivers that happen with women that end up being categorized for crimes that are considered violent really are not. And so, if there are any questions around that, we can talk about that too. But prior to my incarceration, I was division chairperson for Amtrak for New York and DC. And I also had two small businesses. And I share that, meaning that I worked for, a partially government subsidized agency that I had incredible medical insurance. So I, went to doctors regularly, knew everything about my body, obviously. And I was actually diagnosed with uterine fibroids prior to going to prison. So I knew what I was facing. I had been on Lupron, the shot, and I was taking that for several months. And obviously when I came in, I was no longer able to take that. So My bleeding increased. Those things my doctor has suggested while I was on pretrial, because I was actually incarcerated with no bail. And so I had to sit 11 months prior to being actually convicted of my crime. And so I was trying to get a medical leave so that I could get a myomectomy done. And the doctors told me, I'm sorry, the court told me that I could not because of the type of charge that I had, and they would not give me a bail. And so I ended up having my first surgery while I was incarcerated, which is what they told me was a laparoscopic myomectomy. Now, part of that process was, again, I was sentenced but not convicted at this time. And so every time I had to leave to go out to the doctors, they put me in a black and white jumpsuit. This was in Virginia, paraded me handcuffed and shackled, escorted by 2 officers through the front door of the hospital, and just treated me terribly. Number one, whenever I had gotten a exam, I was shackled and handcuffed to the bed, just so they can check me, you know, which I wasn't going anywhere. There were 2 officers who were always in the room with me at any time. And this began just some of my own advocacy work, seeing how I was being treated as a person who was on pretrial and couldn't imagine how people were being treated who had been sentenced and convicted. Nonetheless, I, had my surgery alone. I was unable to have family or any type of support with me. The judge had denied my request to go to my own doctor to get the procedure done. And so when I came out of surgery, I was like, wow, like I don't feel like anything's changed. Now, while I didn't know if I should feel anything immediate, my bleeding had increased substantially. And so I requested my medical records, was unable to get my medical records. The fibroid at the time was 10 centimeters when I went into surgery, and they told me that they had removed it. Fast forwarding, I was sentenced with the federal prison, and I kept telling them that I felt like nothing was done. I didn't believe that there was anything that was done substantial. At this time I'm 35, so pretty much know my body. Again, had regular, doctor's medical appointments, and so knew what was going on. They told me that I needed to get a uterine biopsy. So I told them I didn't need it because I already knew what was going on. I went ahead and got it done anyway. I met with one of the medical health professionals, the doctor who actually told me I needed to get a hysterectomy. And I said, well, I knew that that wasn't the case because I knew what my doctor had told me I needed, and it had not gotten to the point that I needed a hysterectomy. And their comment was, well, you've been sentenced to 130 months. By the time you get out here, you won't be able to have a baby anyway. So you need to go ahead and get your uterus removed, which again was egregious. It was, highly disrespectful. And yet again, learning how they were treating women. Many women I had met had been pregnant while, throughout my journey, seeing how they were being treated, handcuffed, shackled, put into solitary confinement because they were pregnant. If they were, screaming in excruciating pain, they would throw them in solitary. They weren't getting great nutrition, so that they could feed themselves and their babies. And so there was, that process through there. Again, now still in federal prison, complaining about the issues I was experiencing. I went through about 5 pads a day. That's how bad my bleeding was. And I had shared that, I can only buy, and thank God I was, I had resources. So I had to buy a pack of pads. They issued about 10 pads at this time. When you were on your cycle, you could get 10 pads. So that's all that you were able to get. And then you had to buy a pack of pads, which they sold the very cheap pads, a pack of 10, which was about $8. So it was even more than I would have paid when I was, at home. And so I went to the doctor to try to get a prescription for, a better pad, all the things. And so what they made me do in order to get new pads was quantify my cycle. And so they told me I had to put my used pads in a brown paper bag and show them to the officer, who typically was male, in order for him to see that I actually used my pads in order to issue me 5 more pads. And as I stated, going through this on a daily basis, I'm going up to the desk asking for pads every day, showing soiled pads. And for the life of me, I couldn't understand why an officer would want to see this, and why they would even make me go through this. Again, it was not from a humanist standpoint. It was to, continue to strip the dignity from me and the things that I had experienced. I ended up getting transferred to Illinois at this time. And during that experience, there was an outside doctor who came in, and she just touched my stomach and she said, "Oh my God, your fibroids are huge." And I just immediately broke down and cried. And I just could not believe that finally, now at this time, being incarcerated 2.5 years, I finally see a doctor who cared, that actually could just touch the outside of my stomach and tell that there was something, everything that I said was so. And that she said she could put in for me to get the surgery, but did not advise, because I was scheduled to come home. And if I did, that they would have put a detainer on me and I would have been stuck in prison just to get approved to get the surgery done. So I decided not to, because I knew when I came home, I could go back to, whatever medical professionals that I needed to. And so as a part of my reentry planning, I was sent to the Coming Home Clinic, which was at Mount Sinai Hospital in Manhattan. And when I met with the doctor there, because my actual physician was out on maternity leave, and she suggested that that doctor was a good doctor for me to see, that when he ran his test, he said, "Well, you said that they removed the fibroid." And I said, "Yes." And he said, "Well, there's no way they could have removed that fibroid, because the same fibroid that you're saying was 10 centimeters is 16 centimeters now. And so I don't know what they did to you, but it doesn't seem like they did anything." And so I actually needed to get immediate an emergency surgery. They removed the fibroid. At this point, obviously, it was so big, they had to do a C-section. So, there was scarring and all the things that had I actually had to serve out that 10 years, that who knows what would have happened, right? My uterus probably would have erupted. It probably would have been, many things that have happened. And since then, learning around the issues that women were facing with forced sterilization, where in California, there were a bunch of sisters who actually sued the Department of Corrections for what they were doing, telling women that they had to have hysterectomies when they didn't need them. Or women that I was personally incarcerated who was misdiagnosed with breast cancer, had double mastectomies to find out later that they never had breast cancer. And that didn't need to happen. Or would not give a woman a hysterectomy when, again, she knew the things that were happening with her body, end up being rushed to the hospital in the middle of the night because she could have bled to death. And so, these are the things that I have firsthand experienced while inside. Coming home, we worked on 20 pieces of legislation nationally called Dignity for Incarcerated Women, where we ended shackling of women during child labor in 21 states across the country. Also making sure that women have personal hygiene products at no cost to them. And so we were able to make sure that we don't have to pay for pads and tampons. And while it feels as if it is crazy, right, that we would actually have to pass a bill to do that, we did. And we still have to work on making sure that it's being implemented, because there are places still around the country that are still doing this. And so what I have experienced, and also working with HARP, which is the Health and Reentry Project, through CCJ, the Council on Criminal Justice, who I'm an advisor on, and we've been talking about implementing Medicaid for people 60 days before they leave prison, is because of, continuum of care. That often when people are incarcerated and they have substance misuse issues, mental health issues, the only thing that's happening in prison is usually people getting over-medicated. And the things that are happening is they come out with maybe, if they're lucky, 30 days supply of medication. And then after that, there are none. And so what happens, you go to self-medicate to find something, to feel what you've been experiencing the whole entire time, which is numbness while you've been incarcerated. And then you're subjected to, again, being vulnerable and going back through the cycle of incarceration. And so, while I've shared that piece of it, I know that Dr. Trimbur talked about, housing, and, how there are these intersections of vulnerability and poverty because of it. We know that there's not enough affordable housing and what happens. And I focused my work on women because as a woman being incarcerated, that's where my work lands. And so, being the most vulnerable population, being subjected to sexual trauma and violence, domestic violence, human and sex trafficking. I've seen women all over the country. We actually do work in 34 states, and also Bogota, Colombia, and Trinidad. And it is the same everywhere you go. Housing, healthcare, food, and workforce. And when we think about the social deterrence of health, we know that providing these 4 core human rights to people will not only help people with this cycle of abuse through incarceration and the legal system, but also helping people to stay healthy and whole upon return, and also to create better and healthy communities. And so I will stop there if anyone has any additional questions, but I thank you all for the opportunity to let me share some of the experience that I've had, while not all of them, because there are many and great. I felt that that information was most appropriate for this conversation here.
Dr. Sam, thank you so much. I felt such rage listening to you that I felt like I needed to turn my camera off and just like scream into the wall. I'm so sorry for everything that you've experienced, and your ability to talk about it, to share so that we can understand what real people are experiencing is really tremendous. And so thank you very, very much. Dr. Trimbur, thank you as well, just for allowing us to have a place to put our rage. What can we do? How can we help? I want to pause. I often start off asking questions. I have many questions. I have many reactions. I could just talk to y'all all day. I'm going to just pause and see if anyone on the line, either our applicants, our faculty, our community members, have a question or a reaction to what they've heard, especially with you on the line, Catherine, because you're with your Monte family. And so I just want to give people an opportunity to just be in conversation.
Hi,
Anika, you came on and went off again.
Oh,
There you
hi.
go.
How are you guys? Thank you so much for sharing your story. I do have one question regarding something you were talking about. You were mentioning how you couldn't be seen for getting a hysterectomy or getting your fibroids removed because you're in a certain window of getting to be released. Can you just explain how that works?
Yeah, so in the federal prison, or most prison systems, they have to get a waiver in order to get approval for them to allow you to go out for a particular surgery or procedure. And so typically that can take months on end. Sometimes I've seen people wait for a year. And so what the doctor said to me was, if she put in that she felt that I needed to have the surgery right away, that they would put a medical hold on me, which would then keep me incarcerated past my release date in order to get the procedure done. It happens very often where people, because they don't know if they can get the procedure when they get home, they don't know what to expect with the medical system, that they much rather even stay and wait for the opportunity to get what they feel is great health care. And often it's because a lot of people who've gone to prison haven't had great health care prior to going in. And sometimes what they're experiencing to them is normal. I mean, let's face it, in a lot of the clinics in our communities, we're not treated great. And, depending on who you are, your socioeconomic background, your race, your gender identity also determines how people feel about the health system. And so for me, I knew better though. And so that's why I said, well, absolutely not. I'll wait. I went ahead with the advice of the doctor, but also there are some medical professionals that don't feel you deserve to be free. It's unfortunate, but I often talk to health professionals, law enforcement, all types of people, to let them know that while we are in the custody and care, that's what it is. We are in the care of the system that we are in, and it is a responsibility of that system to care for us while we're there. And they don't do that. They want to be over punitive. They treat people worse than they treat their animals. And it is just the most heartbreaking thing that you can see. You know, people, even with legislation, I worked on the Federal First Step Act, and we increased compassionate release. So when you are, you know, very, very sick, you should have an opportunity to be home, get the kind of care you need, or even if you transition, you could transition at home with your family. I'm working right now on a case in Boston with a gentleman who is in his 90s. He is in like final stages of dementia. He's in a wheelchair. He can't do anything for himself. And they will not release him from prison. It has already been in over 30 years. He has family. He has support. People are willing to take care of him. They will not release that man from prison. And so, you know, I heard you talking, Dr. Trimbur, about probation and parole. And often, even with parole, when you think about when people are released or they have to go to the parole board, often they're looking at the nature of the crime. The nature of the crime will never change, right? So if I'm incarcerated for murder, that is the crime. That after 25 years, irrespective of what happened, you should be looking at who I am today and not who I was 25 years ago. That's what parole is about. And often people are then judged by what happened still 25 years ago, no matter what they have tried to do in order to rehabilitate themselves, because I'm a firm believer that prison doesn't rehabilitate anyone either. That people end up being in their, you know, being in their sentence over their parole date, given extra time because of it. Old law prisoners on a federal level, you know, do not even have an opportunity to come home. We change laws, we don't make them retroactive. And so people are aging and dying in prison. And so there's so many nuances, but for those of you who've not had an opportunity to go into a prison, you know, I would encourage you all to. There are ways that you're able to go in, that you can do focus groups, that you can have conversations with people who are incarcerated, to ask them, like, you know, what would you like to see differently? How can we support you better? And also when you think about the continuum of care, what's necessary at that point as well.
Thank you for that. I want to go over to Dr. Swiderski and hear her comment.
Thank you both for eye-opening presentations. I want to ask Catherine a question about those amazing letters. You made it sound kind of easy. I have a feeling it wasn't, and I'm wondering if you could talk to us about barriers, roadblocks, both in getting it set up and in doing it in individual cases.
Yes, I aimed to make it seem easy because I want all of the residents and doctors to believe that this is something they can incorporate into their practice. And some days it's easy and some days it's not, and it's still always, always important. And I think, you know, we really have the luxury of practicing in a time where we have the data, you know, as Dr. Sam was talking about, we have data that shows that these social determinants have very direct links, especially the proximal ones, but the distal ones too, have direct links to the health outcomes. And so, you know, from one standpoint, we actually have increasing data that really shows that if I spend more time upfront, even if I spend my entire visit just working on a letter or getting the data for a letter, that data is that person, right? Again, like one really important part of the letters is that it's strengths-based. And so, and it's understanding the negative health impacts. And so it gives me an opportunity and forces me to ask questions about the person as a person. What are their strengths? What do they identify as their strengths? Like, what things are they working on? What things are they proud of? And so it opens up, you know, a human conversation between two humans. And then it also, I think, just makes us do our work that in a more clinically accurate way. Like I always say to the learners here, like, I did it at my presentation, but you're not supposed to say just heart failure. Like, I want to know what the ejection fraction is. I want to know what the etiology is. You don't just go through and say that they're homeless and pretend like that's not impacting the clinical outcomes that are right in front of me. And so do the work to figure out the pieces of it. And so I would argue that, like, yes, sometimes it makes the visits a little bit longer, but it's much more worth spending that time right now, even if the A1C is 14, because that A1C is going to be 14 if they remain homeless. And it's certainly going to be 14 if they get reincarcerated and then come back out and can't afford their meds. So that's like the sort of theoretical approach. The practical approach is I have an amazing team and a lot of them work really hard. And so I have folks and we included the Docs for Health website that's changing a lot. And so like we may be able to have access to the letter templates on a good day. You just have to like sign in, but I'm happy to share my email and I can send the letter templates to anybody. But we really, our team, again, like the community health workers were like, this is what we got to be doing. And we saw that we were preventing reincarceration. And that feels like the most important thing in the world when you have a patient in front of you who's at risk of going back. And so, we pull on this data. There's this sort of what I was describing earlier there's this contextualizing care data that really shows that if you're addressing proximal, if you're pulling out the social determinants that are the most closely linked, so primarily addressing initially the proximal social determinants, you actually end up saving time down the line. And there's an argument that I mean, you taught me this, but there's a number needed to treat of 6. And there's not a whole lot of meds that do things as important as get people housing, make sure they have food, and keep them from being reincarcerated that has a number needed to treat of 6. So I spend a lot of time on this, and I think that that's better for my patients' health. I also think it's better for their dignity and their humanity. And I think it's better for my humanity because I don't want to be in a world where I'm taking care of people where they're constantly coming in and out of the prison and I'm sitting there feeling like I can't do anything about it, because the whole point of being a doctor is to heal. And so this is the way that I can heal. And so all of that's to say, these letter templates that we did develop and that the rest of my team did a lot of work on. And so my partner, Rahul Manjani, did a ton of work on all of this and worked with our risk department, our legal department, worked with the medical legal clinic, with the law clinic. And then we have a medical legal partnership that we can, there's an article where we sort of described like how we developed this medical legal partnership. And we listened to the patients, we listened to the social workers on our team who really care. And then we listen to the public defenders. And so I'll pick up the phone and I'll be like, this guy, I have a guy right now, he's incarcerated, his colon cancer just came back. He needs to not be at the ACI right now. And so I'm communicating with his PD being like, this is all the context. How do I need to frame it? What do we need to do? Like, this is not okay for him. And so you learn from interdisciplinary colleagues and sort of pull that together. But I'm so happy to share the templates too.
Like Dr. Goss, I love the answer of like, it really does take a team. And I also love that you noted that Dr. Sidursky taught us everything that we know. When we were prepping for this call, Catherine was telling me about setting up a psychosocial curriculum and we both stopped and we were like, Debbie. And so it really is kind of like a full circle moment. I want to acknowledge something that Topeka, that Dr. Sam said that I think is really an important kind of point, is that as horrible and as horrific as healthcare is in the prison system for some people, and I found this for HIV care, the consistency is actually something that they can't get when they come outside. So what does it mean that our healthcare system in the community is so broken? There are people that I met when I was doing work at Rikers who said to me that their HIV is better controlled when they're at Rikers because they can get access to medications and they can get their medications regularly. And it stays with me to this day. And I think a lot about that kind of setup that we have, and how messed up it is in so many different ways. And there's a question from one of the folks on the line that I'm just going to read to you. It's for Catherine, if you don't mind answering kind of shortly so we can get Philip's question and get some more comments. The question is, I wanted to see your perspective on what we would need to do to subvert the clinical setting and to change the way that there are parallels currently between the clinic setting and the panopticon, other forms of policing that exist. When you were saying like hospitals are like prison systems, and when Dr. Sam was mentioning walking in shackled, like what are some things that we can do practically within CHCC and other places that people are practicing to address that?
Yeah, I can answer that in like 2 seconds. It's super easy. Just kidding. I think, one of the things that I think is really important that Dr. Sam, that I want to highlight what you said is you talked about that doctor who finally listened to you. You had the knowledge, you had the expertise the whole time, you knew your body. And I think very simply, the underlying answer to this is believe our patients. They are the experts in themselves. They have a knowledge set that you want to gain. I say to my patients, you're the expert in you. My goal is to know you as well as I possibly can and to always treat you like you are my sister sitting across from me. And that guides me, like that tells me what to do. And I think that fundamentally, tries to push away the hierarchy, the sense of control. We talk a lot about trauma-informed care, and I think we have a lot of buzzwords that we use. But if we think about what really is underlying trauma-informed care, it's giving power back to the person. And that acknowledges that they should have power, they do have power, and they can have power. And if I try to think about all the different ways that I can do that in a clinical encounter, then I think I'm at least working to be a trustworthy person within the system. And then we can kind of, as a team, like we take on the system, like the CHWs and I on our team, we talk a lot about how we, sometimes feel like our work is protecting our patients, from the system. And so that, I think if you have that viewpoint and listen to your patients, they will guide you in terms of what you need to do. Like I've had patients who are like, can you leave the door open? I can't wait in the waiting room. I can't have my back towards the door in the waiting room. So you need to put chairs along the wall so that I don't need to worry about if somebody's coming up behind me. I can't sit in this room because it's reminding me of the prison. So we go for a walk and do the visit after we vital them. We go for a walk and do the visit that way. I think, again, the patients will guide you. And then I think this is where hiring people who have lived experience and not requiring everybody to have a bachelor's degree to do stuff that the bachelor's degree did not train you how to do that thing. And there's a reason why I keep highlighting the expertise of the community health workers on my team. I had amazing training at Monty, but nobody, my patients are the ones who really have guided us on this. And so I think we've got to have people who have lived experience, value that knowledge production, and that really sort of dismantles some of those systems of hierarchy.
Amazing. Go ahead, Philip.
Thank you so much for having the applicants. It's been a really wonderful session. Dr. Trimbur, you mentioned something I had never really thought of, like the risk of reincarceration as in terms of like a social determinant of health. I think of the initial incarceration, but I've never thought of the risk of reincarceration. And I thought that was a really interesting framing. I'm wondering, Dr. Sam, it sounds like your reentry process, you were able to be really successful in that, and had it seem very impressive to me. So I'm wondering if you could talk a little bit about what your reentry process was and what were some of like the sort of like barriers and facilitators to your process that helped you to avoid reincarceration.
Absolutely. And thank you so much, Philip, for that question. Before I answer that, I just want to go and kind of underscore a point that you had made around what Dr. Trimbur had mentioned about, the risk of reincarceration. I thought that was brilliantly said, and that we don't look at it as risk, unfortunately, and it should be looked at that way. So I'll probably quote you on a few other panels that I speak on all the time, because I actually do really, really love that. And also, when you talked about listening to your patient, it's the same like in community, right? Like, my mom is 78. She's recently been diagnosed with lung cancer. She's had this cough forever. She was going back and forth to the doctors. They're like, just take, some cough medicine. Just do this. And she's like, well, this cough. And you can hear her coughing. And I'm just like, no. And we've went to several doctors. Finally, we got them to do, all the CT scans and all the things that I know nothing about. But one of my best friends is a doctor. Another one is a critical care nurse. So they're like telling me what tests to tell them to take in order to find different things. As a matter of fact, tell them to make sure they're doing this test because they find in lung cancer, can be pancreatic cancer too. And my grandmother had, so the doctor, when I'm talking to the doctor's looking at me like, who are you? And where did you get this information from? But if you would have just listened to my mother's cough, right? Maybe, thank God at her age, she was so persistent and that it didn't, go further, so that we caught it in time for her to get the surgery that she needs, and et cetera. So I think you just listen to your patients no matter where they are. I think we'll have better health outcomes just for our people, period, right? Our community. But for me, my reentry process, I often joke and say that, like, when I went into prison, there was an iPhone 3. I came out, it was an iPhone 5. So, like, much in the world didn't change. Technology was really the same. I was already, had a corporate career, was an entrepreneur, grew up, my parents were entrepreneurs, franchise business owners, went to college, had all the opportunities. And so when I came home, actually when I was in and God spoke to me and said what I needed to do, it was very clear for me what my path was going to be. And I focused on that. And so when I came home, I did go to the halfway house because I was released early, and it was terrible. I mean, it was worse than being incarcerated. The conditions were disgusting. I actually was there 3 days, got sick, and had an abscess in my throat just from inhaling the dirt and the dust from there that actually drained. It was the most disgusting thing I'd ever experienced. But having been incarcerated 3.5 years and now coming here for 3 weeks and, I'm sick like this was egregious. And so they finally let me go home. Where I was with my parents for about a year until I moved out and got my own place. I had went back to school. I had done fellowships. I had community. I had mentors and friends who were there for me throughout my incarceration. And when I left, and I went to therapy. I went every single week for the first year straight because I knew while I was unable to articulate the trauma I had experienced while I was incarcerated, I knew that, being separated from even being around men, didn't know how to communicate to men. My body language, how I spoke it just didn't feel like being in crowds. I got high anxiety. Just leaving, going on a subway. I didn't want to be alone because I was so used to I was incarcerated in camps where it was maybe 200, maybe 200-300 people at any given time, and not really in the same place, so you could move around differently. And so but I will say that it was my community of support which gave me the space to feel. It was my therapist who allowed me the opportunity to talk through those experiences and probed with the right questions for me to be able to understand what I went through, but also the traumas that I experienced that led me to incarceration, because I didn't even know what that was. Because while I was in prison, because I didn't have any mental health issues that appeared to be severe to them, and that I wasn't where I was diagnosed to take any type of medication for them, they didn't care. It's just like, okay, just, work out. Or, if you're feeling sick, they would tell you to buy some, expired aspirin off a commissary and lose weight. That's what the doctors would tell you. So it was difficult emotionally. It was difficult even being around my family because they didn't know how to communicate with me. My parents told me when I came home, and I didn't even realize it, I would go out, I would be in school and work during the day. And then when I would come home, I would immediately go into my room and close the door. And I realized through talking to my therapist, it was like I was simulating going into a cell. And so I didn't realize I was just doing that. I would go in, come shut the door, and they wouldn't see me until I left the next day. But it was because I was in such a small, confined space for so long that I had to I was mimicking that same behavior unbeknownst to me. And they never knocked on the door because they didn't want to disturb me because they didn't know. Or when I was going through probation and parole, and I was on federal supervision. And my first probation officer was really supportive about me starting my organization, and understood that I would be around other people with convictions, because in your judgment and commitment, it states that you cannot be around people with other felony convictions. You can go back to prison. And when I was transferred to a new probation officer, she told me I couldn't. She told me if I wanted to leave my jurisdiction, which was Southern District, and go into Eastern District, which could have been from Manhattan to Brooklyn, that I had to call the office to get permission before I was able to leave the borough. Now, I worked throughout the boroughs, but yet the anxiety and things that brought up for me, just having to keep calling, or never had any type of substance misuse issues, but was randomly called in to take drug tests off my job, out of school, just nonsense, you know? And so what I did was end up, I became a Soros Justice Fellow, and I created the Parole and Probation Accountability Project, which was a Know Your Rights guide that I published and gave out to probation and parole offices around the country, where people who were on probation and parole under surveillance understood that they had rights too. And so for me, it was, yeah, well, just because you say this doesn't mean it's so. And I know that I have rights. And so because of who I am, you know, I've always been a fighter. You know, I was also, like I said, I was division chairperson for the union. So, you know, this is part of that. And I've used every experience that was something that felt wrong to me. I would talk to my community about how they were treated, and then I would find a solution. And so that's how I was able to navigate. Ultimately, after I completed 2 years, the judge took me off of federal supervision. I was sentenced to 5 years, but he wrote in his opinion that he thought that supervision was impeding my work. And so he thought to remove me. And so because of that opinion, other people can cite my case if they're doing similar work to get off of probation early. And just, again, doing the legislative advocacy, being connected to my community, because while my best friends, my college buddies, my family were like, hey, you should just be happy you're free. And I'm like, this probation officer should not be doing this to me. They couldn't understand my frustration. And so being around other people who had experienced what I was going through, or presently on probation and parole in community, which is what Columbia University, the Center for Justice, provided for me at the time, I was able to have a community of people that I could talk to that understood, right? And didn't tell me to be quiet, you're free, and that's you should be happy, right? And encouraged me that there was a reason why I should continue to fight.
Amen to that. I'm going to give the, I guess, last question to Omar, and then we'll ask y'all for final comments before we wrap.
Hello, everyone. Thank you for this opportunity, and thank you for sharing your story with us, Sam. My question is, like, being on the side of medical professionals, where the trust of the patients is utmost important. When this kind of trust is breached, like, I think like you had like very good trust with your PCP outside the system, but when you were in the system, this trust was broken. So my question is with Dr. Trimbur, like, how can we ensure that like the trust is maintained? Can we involve like the PCPs outside in like follow-up care of the patients who are incarcerated? Because even I worked in like a prison facility, and we had a lot of bureaucracy where we had to go through a lot of barriers to get access to the PCPs outside.
Omar, I think you're really onto something, because, you know, when Topeka was telling her story, one of the things that came to mind is how great it was that she had a good relationship with her outside PCP and knew what they had told her, had that as a reference point. And it made me think, wouldn't it be amazing if we could be that reference point for so many others? But that question definitely comes up of how do we stay connected? How do we advocate and help while people are incarcerated? Dr. Trimbur?
Yeah, I think it's a really important question. It gets to that dual loyalty thing too, right? Which is that when you are a doc on the inside, I still do palliative care on the inside, but I used to do primary care on the inside. When you're a doc on the inside, your loyalty, your job is to take care of that person in front of you. And yet, for many of us, we are employed by the Department of Corrections, the wardens, the CEOs, security, even here in the hospital, like, we can't just say, go take off those shackles, I need to examine the patient. We have to work up to it. We have to compliment them. We have to thank them for you have to get them to agree to it for you. Because in many states, you can't just say it's this person, you can take the shackles off. You have to you have to massage the situation. And that's true on the inside too, I think. So I think being aware of that dual loyalty is a really important piece to it. Also to keep your own, I think existentially, it's, there's a lot of writing about the damage done to COs and how damaging it is, right? For a lot of COs, they come from the same communities that patients are being incarcerated from. It's a good job. There's a pension, and that's not stuff that everybody has access to. And so thinking about existentially how damaging it can be to both be on the inside, but also be on the inside observing this and witnessing this, and not feeling like you're actually able to tend to people's humanity in the way that you need to be. I think practically what that looks like is, so when we see a patient, the first thing that I do is I have them, if they feel comfortable, sign a release of information for the Department of Corrections, for the courts, for any of the social services agencies that we may work with for the public defenders, so that when they get reincarcerated, I can actually communicate with the docs on the inside. And I have a couple of providers from the inside here who they know that you are not touching my patient on the inside. And I have so much respect for them. And some of them were actually listening earlier. They know not to do and touch my patients until they've communicated with me and they say, okay, what do you want us to do? Like, what things are going on? And so I think, we need to be working obviously at the high level. So for example, Medicaid waivers are being passed in many, many states where people can get Medicaid 30, 60, 90 days activated on the inside, which means that there's a whole host of things that we can do for people, before they're released. But what is states going to do about it? Like, how are they actually going to enact it? Are there people on the inside and people who have lived experience who are going to be participating and saying how we enact that? So I think those are the high level things. And then on the, not low level, but like on my level, building those relationships, like have a PD you can talk to, learn some of the docs on the inside, learn some of the docs on the outside, advocate for community health worker program where some of the CHWs can go on the inside and then be a liaison with the outside, build a discharge planning contract and work with different team members to build those bridges is like a couple of the things.
Thank you so much. And I'm so glad your colleagues were able to be on. And I again want to shout out your parents who are on, if they have any words for you. As we wrap, I just want to give you all a quick moment, a final word. Dr. Goss, one of our faculty members, Dr. Sam, did ask if there's any advocacy around any current legislation that you want to mention that you might need or want our support on with letter writing, calling, our lawmakers, whatever it is that you're doing. We want to support you because this is really important work. So feel free to mention that as well, or to send it over to Jessica and myself, and we'll share it in a follow-up email. But Dr. Trimbur, I'll start with you and then I'll go over to Dr. Sam. Any final thoughts or comments?
Yeah, I mean, I really appreciate it. I hope that I have made clear that we need to hire more people with lived experience and take off the shackles of thinking everybody needs to have a bachelor's degree to do important work. And then I think the last thing, just for the providers and the learners in this group is really remembering that the surveillance that is designed on the inside continues on the outside. That is going to present to you clinically in a myriad of ways. People who've experienced trauma, and I would argue that every incarceration is a potential trauma. We know that any time an ADSEG increases the risk of suicide attempts. Recognizing that exposure is very real and is not always going to present in somebody coming to you and saying, hey, I think that I've experienced some trauma from being incarcerated. Can you help me? It's going to present as people not being able to get to their appointments on time or being triggered and like needing to check out. Dr. Sam, pointed out that like she didn't even know exactly what the trauma was until somebody really worked to sort of, pull that out. And so I think being really open to understanding that the impacts are longstanding, and for many people, they're still under surveillance. Things that are not illegal for other people to do are illegal for people who are on probation and parole to do. Hanging out with my cousin who also has a record could be illegal for me when I'm released, and he may be my primary support person. So I think remembering that gaze, the panopticon, the medical gaze, and that surveillance really continues and gets embodied and is going to present to you in clinic in a myriad of ways. So being open to seeing that and trying not to miss that and tending to that.
Thank you so much. Dr. Sam?
Yes, again, thank you all for being here. you have a lot of people that stayed on. So that's incredible after the amount of time that we spent on this call over. But I would just add that there's a few things. One, just underscoring to listen to your patient, and the fact that, you know, people coming into incarceration, even into community, have experienced childhood traumas, early childhood traumas, other traumas that have happened throughout their lives, which often had to stuff just to continue to live and survive. And so many of us did not know what that was, or even had an opportunity to talk about it or share. And so those things lead you through incarceration. Each person's experience with incarceration is different. The things that lead people to, you know, different things in their life are different. So it shouldn't be looked at that every patient, you know, has a substance misuse issue, or every single patient, you know, even those who have, you know, been back and forth into prison will do it again, right? They're coming to you for support. And often it's not just support on what, you know, is happening with them physically right now. They're also looking for some support guidance on just how they should survive. As it relates to just some of the legislation and things that are passing, just more support around the healthcare waivers and making sure that it's being implemented so that people are actually getting Medicaid prior to them leaving prison, and also support around medical professionals once they leave. What I'm actually doing now is developing a platform, a telehealth platform for people in prison, because I feel like we should all have an opportunity for a second opinion, right? Like, it shouldn't just be because I'm in community. Like, I had an opportunity to take my mother to more than one doctor while I was incarcerated, just because that doctor told me that I needed a hysterectomy. Had I not known that I really didn't, I still should have had the right to be able to reach out to another doctor in order to ask them, based on my health records, what they thought I should do. But unfortunately, all of your rights are taken. But I think that is a basic right that you should have, at least to communicate with someone else about your condition and what your options are. So I will be enlisting all of you, because I need great, you know, healthcare providers who will take your time with listening to people, with really wanting to see if the advice that they're getting is real, right? If they're not just getting pushed under the rug. And so I'm really excited to be piloting that in a few different prisons around the country early next year. So please follow up with me about that, because I definitely need, like I said, the best medical health professionals who really care about my community. Because while I am, you know, removed from incarceration personally, I'm still directly affected because I have family members, loved ones who's incarcerated, and all of the people that I've left behind. And so this is really important to me. And it seems like it is to you all. So I thank you so much again for being here and just caring about us.
Thank you both so much. We have a lot that we're going to share definitely from this conversation. Just two quick things that we would love to hear your feedback, if you're so inclined. And we will see y'all for our November 28th rounds. But I really do want to kind of leave on this note of, you know, there is more that we can do. There is tremendous amounts that people are doing through clinical care, like Dr. Trimbur, through advocacy and just like lived experience leading change, like Dr. Sam. And it's just exciting to imagine doing this journey with you. And I want to plug Monty. You know, we get trained in really thinking about how to do this type of medicine, and you're living in the Bronx, Dr. Sam. So definitely like pick on the Monty collaboration, because people would be absolutely interested to support this work. I think it's incredibly important work. So thank you all for
walk to Montefiore.
Yes, right? Good. Perfect. So you're right in our backyard. I say this as I'm living in Brooklyn. But anyway, I'm sending all of you peace and peace of mind as we head into whatever the future brings. And I hope that these rounds have been enjoyable to you. Please do leave us feedback. Thank you again to our speakers and to our program leadership for giving us this platform to share this information. All right. Have a great night, everyone.
Thank you for organizing, Stella.
My pleasure.
Thank you very much.
You're welcome.